Morning all. My topic for today is case history. Case history is very important as far as orthodontics is concerned. Of course, we take case history for all departments and industry. And now I will be doing a class on case history in perspective for the orthodontics department. So, what is case history? It involves eliciting and recording of relevant information from the parent and patient to aid in overall diagnosis of the case. So case history is an essential diagnostic aid. Now, first thing what we should do when a patient comes to you is you must collect the personal details of the patient. Name, of course, everything starts with a name. You have to record the patient's name. It is recorded for the purpose of communication and identification. So most patients like being called by their name. It gives a personal vibe to them, and it has also got a beneficial and psychological effect. Of course, we always like ourselves to be called by our own name. You know, and if a patient is a child, it is always good to record his or her pet name so that they feel they are in a more friendly environment. Now, age of the patient. Now, this is quite important. Age of the patient, because always a patient's chronological age is to be recorded. Certain transient conditions like ugly duckling stage that is seen during the development that are normal for that age and does not need any treatment. We can only identify that only if we record the age of the patient correctly. Certain treatment modalities that are done in growing age. For example, certain growth modification using functional and orthopedic appliances can be done only in a certain particular age group. So recording of the age is of paramount importance in case of an orthodontic case history taking. Also, certain surgical procedures can only be done after growth cessation, and this can also be properly assessed only if you know the right chronological age of the patient. Now, address and occupation. Why address and occupation is important? It helps to understand the socio-economic status of the patient and parents. So it helps us to communicate, in future appointments, if you want to schedule future appointments, if you want to reschedule them. Address is always important. Address is always an important detail that we must collect. Now, chief complaint of the patient. The chief complaint of the patient should always be recorded in his or her own words. It helps the clinician in identifying the priorities and desires of the patient. So only if we know what the patient wants, only then we will be able to make him or her happy. So it can be elicited by an interview or asking the patient to fill up a questionnaire. That depends on individual preferences. You can do either way. Now, usually the complaint may be aesthetics or an impaired function, or maybe a combination of both. Next, we come to medical history. Why medical history in orthodontics is important? Say, if we have a patient who has a history of epilepsy, then orthodontic treatment has to be delayed until it is controlled. It is unfavorable for us to have any kind of seizures or any epileptic attacks when we have a fixed orthodontic appliance in place. Now, hemophilia, blood dyscrasias. Special management is to be required in cases where extraction is required. As we know, almost 70% of cases require extraction in our orthodontic department, and hence it is imperative that we know any medical history of the patient who might be having any sort of blood dyscrasias, hemophilia, etc. Diabetics can undergo treatment if diabetes is under control. If diabetes is under control, then there is no issue and they can undergo treatment like any other normal patient. Rheumatic fever or cardiac abnormality. Now, these require antibiotic coverage for certain dental procedures. As we know, when we do procedures like extraction on patients with rheumatic fever or any cardiac abnormality, we always give a prophylactic amoxicillin dose 2 grams before 1 hour before the procedure. Physically or mentally handicapped children require special management. Of course, we know why it is so. We should be able to We should be able to assess the kind of cooperation that we may get from our patient, and then we have to plan the treatment accordingly. We have to ask about the drug history, because certain drugs like aspirin, they impede the orthodontic tooth movement. So drug history is also very important. And in case of viral fever, we always have to allow the patient to recover prior to initiating the orthodontic treatment. Now, dental history. What we should ask about? We should ask about the age of eruption of teeth, history of extraction, restorations, trauma. Dental history helps us in evaluation of patient and parent attitude towards treatment. For example, if we have a patient who has regularly done restorations and who is having proper hygiene maintenance, then we can understand that the patient is serious towards his or her dental health, and we can also understand the parent attitude of that patient, that they are also uh, sincerely concerned about the oral health, and they will be more cooperative with us in case of orthodontic treatment. Prenatal history. We have to ask about the condition of the mother during pregnancy and the type of delivery. Then certain drugs like thalidomide and certain infections during pregnancy like German measles result in congenital deformities of the child. We have to ask about the type of delivery, whether it was a normal delivery or a forceps delivery. Forceps delivery can cause TMJ injuries resulting in mandibular growth retardation. You can see these images and you can appreciate. See the kind of damage that forceps delivery brings with, and I think nowadays it is very minimally used. Now, coming to family history, we have to ask if skeletal conditions like class 3, class 2 malocclusions and congenital conditions like cleft lip, palate are inherited. Now, Habsburg jaw, we all know about the Habsburg jaw. That is the European royal family, all having skeletal class 3 manifestation. So we know the studies regarding that, the twin studies, yes, we've read about it, and we'll talk about it in detail when it comes up. Next, let's go to general examination. Height and weight of the patient. Height and weight always gives us a clue to the physical growth and maturation of the patient that may have dentofacial correlation. So we can use a Wetzel's grid to assess the correct height and weight for a particular age. Also, we can use the simple formula. The height in centimeters minus 100 gives the ideal weight in kilograms. So this is also a very simple formula where we can easily identify if the patient is overweight, underweight, and so on. Gait. It is the way a person walks. Abnormalities of gait are associated with neuromuscular disorders that may have dental correlation. So basically, we can understand a lot by asking the patient to just walk a few steps from your dental chair to a nearby point. So you must do it. You must do it as a part of your examination. Gait is very important. It should be recorded, and it will always give us clues whether the patient is having any neurological problems. Now, posture. Posture refers to the way a person stands. Abnormal postures can predispose to malocclusion due to alteration in maxillomandibular relationships. So, upright posture is most ideal, and we should assess the kind of posture that a patient has. Now, the body built, that is a physique. It is of three types. Aesthetic, that is a thin physique with a narrow dental arch. Then we have plethoric, that is obese with large square dental arches. And then we have athletic, that is a normal build with normal size dental arches. So let's see Sheldon's classification of body built. He classified them as ectomorphic, that is tall and thin physique; mesomorphic, that is the average physique; endomorphic, that is a short and obese physique. So you can easily see from this image what an ectomorphic person looks like, what a mesomorphic person looks like, and what an endomorphic person looks like. Now let's come to extraoral examination. Shape of head. It is classified into three types: mesocephalic, that is the average shape of head with normal dental arches; dolichocephalic, that is a long and narrow head with narrow dental arches; brachycephalic, that is a broad and short head with broad dental arches. So you can see from this image what a brachycephalic head looks like, what a dolichocephalic head looks like, what a mesocephalic head looks like. Okay. Next, let's come to the shape of the head evaluated by cephalic index of head. So what is cephalic index? It is based on anthropometric determination of maximum skull width of head and the maximum length. So cephalic index is maximum skull width divided by maximum skull length. So into 100. Now skull width is measured by the distance between tangents to the parietal bone, and skull length is measured by the distance between tangents to the frontal and occipital bone. Very easy to visualize, isn't it? So as I said, skull width is between the tangents of parietal bones, and skull length is between the tangents of occipital and frontal bones. So in a dolichocephalic patient, the length is always greater than the breadth. In a mesocephalic patient, the length is more or less equal to the breadth. In case of a brachycephalic patient, the breadth is always greater than the length. So in a mesocephalic patient, there is an average shape of the head. They possess normal dental arches. Cephalic index comes between the value of 76 to 80.9. I hope you all can just memorize these values as they can be helpful. In case of a dolichocephalic, it is long and narrow head. They have narrow dental arches. So the cephalic index is less than 75.9. In case of brachycephalic, the patient has a broad and short head. They have broad dental arches. The cephalic index value is between 81 and 85.4. In case of hyperbrachycephalic, the patient has an extremely wide head and the cephalic index value is more than 85.5. Now in case of facial form, face can be classified as round, oval, or square. Another classification is mesoprosopic, that is an average or normal face form, and euryprosopic, that is a broad and short face form, and leptoprosopic, that is a long and narrow face form. The face is classified based on facial index. Facial index is a morphological facial height divided by bizygomatic width. Facial height is measured by distance between nasion and gnathion. Bizygomatic width measured by distance between tangents of two zygoma points. So the facial form, mesoprosopic, that is the average or normal facial form. The index value is 84 to 87.9, and the normal U-shaped arches can be seen. In leptoprosopic, long and narrow face form, index value is 88 to 92.9. The narrow apical basal arches can be seen. Hyperleptoprosopic is the extremely long face. The index value is greater than 93. Europrosopic is a face is broad and short, 79 to 83. So you can see broad and square arches. In hyperuroprosopic, it is a short with low facial index. It is less than 78.9. You can see the index value is less than 78.9. So I hope you all can just memorize these values as they can be helpful for your exams. And you can easily correlate between the mesoprosopic, leptoprosopic, and europrosopic facial forms and the arch forms concomitant to that. I already spoke regarding this. This image is self-explanatory. Yeah. So the dolichocephalic head is mostly associated with leptoprosopic face. Brachycephalic head will have europrosopic face. Sometimes head and facial form may differ, and they are called dinaric individuals. Now, how to assess facial symmetry clinically? In a vertical plane, you hold a scale connecting nasion, bridge of nose, tip of nose, philtrum of upper lip, and midpoint of the chin. In the symmetrical face, all these points will be on the same line. In an asymmetrical face, the scale of the chin region tilts towards the underdeveloped side. So they say that asymmetry is very common, and mostly the levels are very mild. And a fun fact, they found out that one of the most symmetric faces belong to beloved Hollywood actor Denzel Washington. Yeah, so you can see his face. Yeah. So transverse facial symmetry. Ask the patient to hold the scale in mouth with the head straight. In symmetric face, the scale will be parallel to the floor. In asymmetric face, the scale tilts upwards towards the underdeveloped side. Another method is you ask the patient to extend his neck back like you see in the image and visualize the patient's face from chin region. Midpoint of the chin, tip of nose, and nasion, glabella, they all must be in the same point if the patient is symmetric. Now let's come to vertical facial proportion. So the upper facial height, middle facial height, and lower facial height. So the face is divided into three as shown in the image. The vertical height of the mid face should be equal to the height of the lower face. In lower face, mouth equals 1/3 between the nose and chin. So, there is something called golden proportions that we will talk about later. So the golden proportions will give a better idea on the vertical facial proportion. That in itself is a short note and will be discussed later. Now, gross facial asymmetries are seen in conditions like congenital defects, hemifacial atrophy, unilateral condylar ankylosis, and hyperplasia. Now, these all should be noted in the initial examination. Now, let's come to the facial profile. Ask the patient to look at a distant object with the Frankfurt horizontal plane parallel to the floor. Facial profile is assessed clinically by viewing the patient from the side. The profile is assessed by two reference lines, a line joining the forehead and soft tissue point A, a line joining point A and soft tissue pogonion. So based on relationship of these two lines, the profile is of three types. It is either a straight profile, the two lines are nearly straight, or a convex profile, the two lines form an angle with the concavity facing the tissues as seen in the image. It is seen in class 2 division 1 malocclusion, or a concave profile with two lines form angle with convexity towards the tissues seen in class 3 malocclusions. Now, facial divergence. Facial divergence is defined as an anterior or posterior inclination of lower face relative to the forehead. It is of two types. Anterior divergence, that is a line drawn between the forehead and chin, is inclined anteriorly towards the chin. The posterior divergence, that is a line drawn between the forehead and chin, slants posteriorly towards the chin. Straight or orthogonathic, that is a line between the forehead and chin, is straight or perpendicular to the floor. Now, let's come to assessment of anteroposterior jaw relationship. You have to seat the patient upright in the dental chair and ask them to occlude gently on the posterior teeth. You ask the patient to gaze at a distant point to bring the head to the neutral position with the Frankfurt horizontal plane parallel to the floor. Now you place an index finger and middle finger at soft tissue point A and B respectively. In skeletal class 2, the index finger is anterior to the middle finger or the hand points upwards. In a skeletal class 3, the middle finger is always ahead of the forefinger or the hand points downwards. In skeletal class 1, the hand is at an even level. So you can see from this image how the simple test can be done. Now, the assessment of vertical skeletal relationship. Vertical skeletal relationship can be assessed by studying the angle formed between the lower border of mandible and the Frankfurt horizontal plane. Normally, these two planes interact at the occipital region. Now, these are all simple things that you can do during your case history, and I hope you should practice this on a regular basis. If two planes meet beyond the occipital region, it can be considered as a low angle case or a horizontally growing face. Now, if two planes meet anterior to the occipital region, then it is a high angle case or a vertical growing face. A reduced lower facial height is always associated with deep bites, and increased lower facial height is associated with open bite. So we will discuss regarding this in detail in the next class. We will stop here, and we'll continue with the rest in the next class. Thank you.